Okay, sir, we are live in 5, 4, 3, 2, 1. Please start, sir. We are live.
Hello, good evening, everyone, and it's a great pleasure to welcome you all for this exciting webinar, Oncology 2022. And today is the first day, very specifically on hematological malignancies. It's a great pleasure to welcome both the organizers, Dr. Ankur Mittal and Dr. Ashwin Philip. For the day one today, it's a pleasure to welcome Dr. Ankur Mittal, consultant hematologist and bone marrow transplant physician at MD Oswal Hospital, Ludhiana. Good evening to you, Dr. Ankur, and it's a privilege and honor to welcome you. We request you to set the ball rolling and do a welcome and introduction. Over to you, sir.
Good evening, everybody, and thank you, Tarun, for the kind words. It's a really pleasure to welcome you all today for this 2 days of scientific feast on hematological malignancies and lung cancer. I welcome all my respected teachers, seniors, friends, and the colleagues for the today's feast. We know that there is a lot of clinical updates have been published and are relevant to our day-to-day clinical practices. So today webinar would be focused on the hematology updates, and I'm really honored to have the best faculty in the field for the today's discussion. So without much delay, it's a pleasure to introduce the chairpersons for the first session. And I know these the chairpersons, they don't need much introduction. So the first chairperson is Dr. Subhash Verma. He's a director and Director of Hematology Services at Fortis Mohali. And the second is Brigadier Sir Dr. Ajay Sharma Sir, and he's a Director of Hematology and Bone Marrow Transplant Services at Paras Hospital, Mohali. Over to you, sir. And I'm really honored to have both of you as a chairperson for the today's feast.
Thank you. Ajay, good evening. Are you going to start?
Good evening, sir.
Good evening.
So shall we start with the program? It's great pleasure to invite Dr. Vinod Patil, who is head of the Department of Hematology and Bone Marrow Transplant in the Oncology Cancer Center, Satara in Maharashtra. Dr. Vinod, I welcome you on behalf of all the organizers and all of us sitting here. Dr. Vinod is going to talk to us on the role of ATG in aplastic anemia in elderly. As we know, in elderly, the management of aplastic anemia continues to be a problem, and many of us are a bit skeptical of even using ATG, and more so now because we have some other alternatives available, but ATG has got a definitive role in aplastic anemia in elderly population also. That is what Dr. Vinod is going to talk to us today. Dr. Vinod, all yours. I welcome you once again.
Good evening, sir. So just wanted to share something. Actually, there is some issue with my slide sharing actually. So I just talked to the team. So it will be my pleasure. I will be up.
So
hello,
we'll
can you hear
be
me?
sharing your slides. Yes, sir. We'll be sharing your slides.
Will you share
So,
my slide? Yeah.
Yes. So we will share your slides, sir. For every slide, you just have to say next.
Sure, sir, sure.
So sorry to say,
can we have the next speaker? So can we have the next speaker till the time Dr. Vinod shares his slide with us? Can we have the next speaker, please?
Sure, we can do that.
Okay, Dr.
And
Dr. Subhash, sir.
yeah, I think we will go ahead and request Dr. Mukesh Chawla. Dr. Mukesh Chawla, who's consultant hematologist and bone marrow transplant physician at Indus Hospital, Mohali and Derabasi. Mukesh is going to talk to us about innovative journey of Eltrombopag in addressing the unmet needs of aplastic anemia. Mukesh, are you there?
hello. Yeah, good evening, sir. Good evening, Dr. Subhash, Dr. Ajay. Good evening. Sorry, I was just uploading my slides. Yeah, I'm there. Thank you so much, sir. Just a second. I'm just sharing my screen. Slideshow. Can you see the slides?
We can
Yes,
see your
yes, we
slides
can
if
see
you
the slides. Yeah, you can put into the presentation mode.
This one.
Sir, can we share your slides from our end? Sir,
Yeah,
unmute
it is
yourself.
not opening from here actually.
Mukesh, can we share us your slides from our end?
Yeah, can be done.
Yeah.
Can see if I'll try sharing from here.
We can see these now. It's a full screen.
Can you see now, sir?
Yeah.
Everybody?
Yes, yes, we can.
Yeah. So shall I start?
Please do.
Yeah. Good evening, all. So thank you for this opportunity, organizers and the chairperson, for being the speaker. And my topic for today will be innovation journey of L-Trombopag, addressing the unmet needs of the in severe aplastic anemia. So this talk in association with Novartis. So our agenda for today evening will be, so we'll have a brief discussion about severe aplastic anemia and current unmet needs with the management option. And we'll be discussing on transplant and standard immunosuppressive therapy. And then we'll talk about the innovative journey of L-Trombopag and then summarize the clinical innovation. So as we know, severe aplastic anemia from the 1970s, they've shown that the majority of the patients die from the disease within almost like 80 to 90% of the patient die within 1 to 2 years. And mostly patients are less than 35 years. As we know that the severe criteria for severe aplastic anemia is platelet less than 20,000, reticulocyte less than 1%, ANC less than 500, with very severe aplastic ANC less than 200. Severity criteria, and based on depth of cytopenias, we established the identity patient at a particular risk. As we know that aplastic anemia, there is a bone marrow destruction and it is an autoimmune disease. So there is an immune response led by the expansion of the cytotoxic CD8 population, which target the CD34 hematopoietic stem cells and the progenitor cells, as you can see. So there are different pathways: fast receptor, fast ligand pathway, interferon, TNF alpha, which induces apoptosis leading to hematopoiesis and followed by a hematopoietic failure leading to a replacement of the hematopoietic stem cells by the fatty spaces. So clinical manifestation, as we know, it can be present abruptly or within weeks or months. It's a biphasic onset with the typical symptoms consisting of symptoms of anemia, thrombocytopenia, and neutropenia, which include bleeding manifestations as well as infections. The criteria for severe aplastic anemia, as we know, it is less than 25% of the normal control or 25 to 50% with residual hematopoietic stem cells less than 30%. And either two of the following peripheral blood criteria should be present, like ANC less than 500 per microliter, platelet count less than 20,000, and reticulocyte less than 40,000, and very severe aplastic anemia with the ANC of less than 200. So diagnosis, as we know, it's a detailed, we need to have a diagnosis of exclusion also. We start with CBC, retic count, PBF, and bone marrow examination studies, which include aspirate as well as biopsy. Then we do a chromosomal breakage analysis to rule out inherited bone marrow failure syndromes, flow cytometry to detect the PNH clone, and various cytochemistry chemistries like B12 levels, folate levels, LFTs, viral studies like hepatitis virus studies, CMV, HIV, autoimmune workup of ANA, anti-DSNA. Not all patients we get it done. Chest X-ray, ultrasonography, and echocardiogram to rule out the other causes. And we make a diagnosis of aplastic anemia, and there are some emerging tests which are coming like leukocyte telomere length, NGS studies, SNP array karyotyping, which are still not into our clinical scenario to diagnose aplastic, but they are coming up in a big way. Treatment algorithm as per British Committee of Hematological Society UK guidelines, we know that it depends upon of the age of the patient. Less than 35 years, 35 to 50, and more than 50 years, less than 35, you have to go for the transplant. Look for HLA match. If yes, go for transplant. No, then very young age, like children less than 20 years, you should going for MUT unrelated transplant, or even haplo they advise these days. If still not there, then you go for an immunosuppressive therapy with horse ATG and cyclosporin levels, no response. Then you go for the other types of transplant more than 50 years. So transplant is not upfront. You go for the immunosuppressive therapy, no response is there. Then you look for the transplant candidate. If sibling, yes, we go ahead. Otherwise, you go for unrelated. 30 to 35 to 50 years a gray zone. Depending upon the clinical condition of the patient, you decide whether he's a candidate for transplant if match sibling is available, or immunosuppressive therapy. And in case of relapses, you challenge the patient who have gone upfront with the ATG. You give a second round of immunosuppressive therapy, or go for the transplant if a candidate is available. So what are the treatment options? As we know that curative treatment is hematopoietic stem cell transplant, 90% disease-free survival is there. What are the advantages? There is a marked reduction in the risk of relapse and late clonal disorders as compared to the immunosuppressive therapy. There are a lot of predictors of outcome like match sibling donor is available, age, young age, less than 16 years. If early transplant, like from the time of the diagnosis, within 3 months, if you transplant, the outcomes are better, and a conditioning regimen containing non-radiation conditioning. So this, as you can see, the best outcomes are with the better with the sibling transplant rather than the unrelated. And also age is a strong effect, has a strong effect on the survival of these patients. Like as you can see in the age group of 1 to 20, 21 to 40, and more than 40, there is an increase, the results are less with the increased risk of mortality. So this paper from Blood 2018 has shown that this in people of severe aplastic anemia with age of more than 40, the transplant outcome has not much improved. So it has almost remained unchanged. Like in the last 2 decades, if you see, like from 2001 to 2009 and 2010 to 15, the outcomes are almost similar. It has remained unchanged in the patients with the age more than 40 years who are undergoing transplant for severe aplastic anemia, even after correcting for the confounding variables like age, donor type, and type of T cell depletion with ATG. So now we come up to, if beyond now we are looking for non-eligible transplant candidates. So what is the option? So immunosuppressive therapy with horse ATG plus cyclosporin is the standard of therapy, and it responds in almost 50 to 70% of cases. And age is an important predictor of the outcome. However, the rate of secondary malignancy and clonal evolution is higher as compared to the transplant patients. So as you can see, there is a lot of unmet need with the immunosuppressive therapy. How we see that? Because not all patients have a complete response to the ATG cyclosporin. Only 10% of patients have a complete response. And almost like 1/3 to 1/4 of patients do not respond. And approximately from the responders, around 30 to 40% of the patient relapse. And approximately 40% of unresponsive patients who don't respond, they die within 5 years of diagnosis. So there is a whole area of unmet need for these kind of patients. So so we need to understand what are the unmet immediate patient needs for these non-transplant eligible patients. Like there is a persistent low blood counts, associated complications, the repeated transfusions and hospital visits, concern about the safety and the death event. So now coming to the further therapies, we'll talk about the L-Trombopac, its innovative journey, how it came into. Before that, multitude of drugs were tried, like androgens, high dose steroids, cyclophosphamide, high dose, moderate dose, other immunomodulators like MMF and sirolimus, along with GCSF, but no one showed an improvement in response or any survival rate. However, they're associated with more toxicity. So none of these agents could make it to the treatment profile of these patients. So we need to understand why this unmet need is there, because there is a chances of why this immunosuppressive therapy fails, because most of the patient present late to us. So it depends upon the presence of the residual stem cell number at the presentation of the patient. So if the patient present late, so mostly elderly uh, patient present late to us where the reserve of the hematopoietic stem cells have gone down, so the probability of failure, so as the stem cell number goes down, the probability of failure for the immunosuppressive therapy goes high and the probability of recovery goes down. So how this L-thrombopag helps? It causes the stimulation of the hematopoietic stem cells, and there are other mechanisms also which increase the probability of hematopoietic recovery and also increases the immunosuppressive effect of ATG as well as cyclosporin. So coming to L-thrombopag, we'll just go a little bit about its biological background. It's a TPO receptor, so it's a TPO mimetic. So there is a TPO receptor on the cell membrane of the megakaryocytes and other progenitor cells. So it is a mimic of the thrombopoietin and gets internalized to the inside the cell membrane in the cytoplasm and leads to the activation of the JAK state pathway and the RAS MAPK pathway, leading to signal transduction and transcription and leading to the proliferation of the hematopoietic stem cells. So TPO acts through the TPO receptors, which is essential for the normal thrombopoiesis. As you can see, this is the normal hematopoiesis, which goes through the various stages. As you can see, this thrombopoietin receptor is not only just present on the megakaryocytes, it also present on the early precursors and the progenitor cells also, like myeloid erythroid precursors, committed myeloid progenitors, and the hematopoietic stem cells. So as a result, it acts at the multiple levels to stimulate the hematopoiesis and expands the hematopoietic stem cells, which are defined phenotypically and functionally in vitro. So there are various studies where they have knocked out the thrombopoietin and CMPL, which is the thrombopoietin receptor in mice, which have shown the reduced hematopoietic stem cells. And also in patients with CMT, congenital amegakaryocytic thrombocytopenia, where there is a mutation of loss of function in CMPL, which not only leads to just thrombocytopenia, but later can develop into multilineage marrow failure. So it stimulates all the cell lines of the marrow and lead to trilinear hematopoiesis. So then it was tried as a salvage therapy in relapsed and refractory patients as a monotherapy, and first study was a pilot study by the NIH. So just a brief about that: 25 patients, refractory severe aplastic anemia, dose was 50 to 150 mg for 12 weeks it was found, and there was found 44% of hematological responses of at least one linear one cell line. So platelet responses were 36%, HB responses around 24, ANC around 36%, and there was so first primary endpoint was the 12-week and followed up to 1 year, and they have shown in the biopsies also there was increase in the marrow cellularity also. So this is another slide where they have shown the individual patient profile, how their platelet count with over the time have increased, HB levels and absolute neutrophil count. So then other article where it has shown that L-thrombopag restores trilineage hematopoiesis in refractory severe aplastic anemia, and that can be sustained on discontinuation of drug. So they tried for some time and discontinued on that. There were additional 18 patients. Overall response was around 40%. And long-term follow-up, they discontinued in 5 patients, which had robust and sustained responses. And median response rate was around 28.5 months. So L-thrombopag, it was found that the L-thrombopag promotes hematopoiesis in patients with severe aplastic anemia by stimulating progenitor cells and can be discontinued safely in robust responders with the maintenance of the hematopoiesis. And clonal evolution was found in mostly in the non-responders. As you can see, mostly had this monosomy 7 deletion 7q and trisomy 8 other also their deletion 13q, and mostly it was in the non-responders and very few in the responders. So then it was tried as a frontline therapy as an add-on to the standard immunosuppressive therapy. Just a brief about the study. It was a phase 2 open label interventional single arm sequential cohort study of L-thrombopag in combination with the first line standard immunosuppressive therapy in patients with severe aplastic anemia. So there were total 92 patients and divided into 3 cohorts, 1, 2, and 3. All the patients received horse ATG with cyclosporine from the day 1 to 6 months. So how they divided in the cohort 1, L-Trombopag was started from day 14 and continue up to day 6 months. And cohort 2, day 14 to 3 months. Cohort 3, they started from the day 1 itself to the 6 months and followed up to 5 years. So, so they defined
Dr.
the CR.
Mukesh, you will have to summarize soon.
Yeah, right, sir. So CR, it was around 58% with historical around 17%. Overall response was 94% around, and historical it was 66%. And median days for transfusion independence, RBC was 39 days and platelet transfusion was 32. Overall survival was 92 at 2 years. So this study showed that it addressed most of the unmet needs. However, there was no randomized control trial. So then, so just a brief about the phase 3 RACE trial, which was a randomized control trial. So so there were 2 arms, A and B, with the addition of the L-Trombopag in the other arm, and the primary endpoint was a hematological response at 3 months. So started from 2015 to 19. 205 patient analyzed 197. A arm has 101 and B has 96. Comparable in the all the characteristics in terms of age criteria, gender, everything. So it was found that at the 3 months, the CR in the arm A was 10% and 22% in the arm B, with overall response of 31 and 59%, which increased to 20 and 32% at 6 months. So they divided in the, they found subgrouping analysis also in the severe and very severe aplastic anemia, and also accounting the age. They found that the responses were better in the group B. As you can see this, the overall response at 3 months was 66 and at in arm B it was 76%. And transfusion independence was median days was 51 and platelet was 40 days. Serious adverse events were almost comparable. Fatal cases were, however, less in the arm B L-Trombopag. However, the GI side effects were more common in the L-Trombopag. Clonal evolution was not very significant in the 2 groups. So overall survivor was, however, not very, 2-year overall survival is not very greatly different in the 2 groups. It was around 85% in group A and 90% in group B. So just coming to this, so this is a strong evidence. And also they found that the rapidity of the response was high earlier in the group B. So it was around, the average duration was around 3 months in the group B with L-Trombopag, and around 8 to 9 months in the 8.8 months in the group A. So now we have a strong evidence from a randomized control trial with the L-Trombopag addition to the standard immunosuppressive therapy, which address most of the unmet needs of the patient. And a new algorithm has been suggested, which includes L-Trombopag as a combination in addition to the standard immunosuppressive therapy. Thank you so much.
Thank you, Dr. Mukesh. And may I request my co-chair to invite Dr. Patel now for his talk?
Yes, sir. Thank you, sir. So I think
Sir, your voice is not clear. Sir, your voice is not clear.
With all the slides.
Yeah,
Actually,
Dr. Mukesh, sir, can you just stop here?
I would say, but
so can we have the slides for Dr. Vinod Patil, please? Great. So Dr. Vinod, sir, you just have to say slide next, and next. Or over to you, sir. You have 15 minutes for your presentation.
So, thank you, the organizers, for the opportunity given, and I'm really sorry for the technical glitch that happened. So I'm presenting my presentation now. So my topic is immunosuppressive therapy for aplastic anemia. Next slide. The algorithm of management that we usually follow is on left side. That is initial management. If patient is diagnosed with aplastic anemia, if less than 40 and got matched sibling, it's sibling transplant. If more than 40 no matched sibling, we go for ATG plus cyclosporine. If there is a response, we continue the treatment and we follow the patient for long term. If there is no response at 6 months, then for match unrelated donors in children and young adults, we go for unrelated transplants. And for more than 40 with having a sibling match transplant, we go for transplant. If there is no transplant donor available, we can repeat the immunosuppressive therapy with rabbit ATG with cyclosporine, or we can utilize alemtuzumab in those cases. If there is no response at 6 months, even with these all treatment lines, then for non-transplant options are androgens, GCSF with erythropoietin, supportive care, and experimental protocols like Eltrombopag and all. If there are options for transplant, we will definitely go for MUD or haplo or umbilical cord transplant. The proposed treatment algorithm that is on right side is the latest publication in Bone Marrow Transplant Journal. What they say is, if patient is diagnosed with transplant, if age is less than 40, if there is a match-related donor available, we'll definitely go for transplant first. If there is no match-related donor available, we'll go for immunosuppressive therapy. If it fails, then if patient is having match unrelated donor and less than 20 years of age, and donor is available, we will go for that transplant. And if it is haplo or umbilical cord available, if there is no MUD available, we can go for that option. Donor, and if there are no comorbidities, we can go for transplant even those cases. If there is no match related donor available and patient is not fit for transplant, if first line it is not available with match related donor, then we can go for haplo transplant in those cases. If age is more than 50 years, even then also we can think of transplant if patient has very good performance status, and if patient is having age more than 60 years, go for immunosuppressive therapy, and if there is no response, then we can think of transplant options. Next slide. So the age effect of transplant in please the previous slides, please. Yeah, so there is strong age effect after the transplant patient from an identical sibling. We can see those patients who are 1 to 10 years, there is 86% response rate. For 21 to 40, it is 76%. And for more than 40 years, it's around 55%. Next slide. Again, for unrelated donor transplants, age definitely matters. 85% for the 1 to 10 years, for 77% for 11 to 30 years, and lesser for the patients more than 30 years of age. Next slide. Then those patients receiving the immunosuppressive therapy, again, age again plays the important role. Age 1 to 20 years, the response rate is 82%. For 21 to 40, it is 69%. And for 40 years, more than 40 years, it is 58%. Next slide. Yeah, so about the mechanism of action of ATG and cyclosporine. So first, the etiopathogenesis of aplastic anemia. An unknown antigen is presented by the antigen presenting cells to the T cells, and T cells cause cytokine release, and they cause inhibition of the stem cells, and that leads to aplastic anemia. The naive, if we see below, the naive T cells undergo activation in the because of interleukin 1 and 6. They get activated, and the differentiation occurs under the influence of interleukin 2, 4, and 6, and then T cell expansion occurs. Next slide. Yeah, keep on pressing on that. Yeah. So what cyclosporine and ATG does? Previous slide, please. Yeah. So what cyclosporine and ATG does? Cyclosporine inhibits the interleukin 1 and interleukin 6, and it prevents the T cell activation, while ATG causes suppression of the effector mechanism, that it reduces the cytokine release, as well as it inhibits the T cell expansion cases. Next slide. So this is a Swedish data that in the left side, the data presented is the different type of treatment options and what is the response rates. So transplant, 96% response rates, immunosuppressive therapy around 68.9% response rate, while cyclosporine alone or without any specific therapy, the response rates are 29.6%. On the right side, the data it mentions about the immunosuppressive therapy and different response rates according to the age. For younger age, the response rate is better compared to the older age. Next slide. So for ATG, if it is given And if it is followed over 10 years, if we see over the year, the response rates is better, 49 to plus or minus 7% or 62 plus or minus 3%. And for 74 to 30%, 3%, and 72 plus or minus 6% as the years progress. Next slide. So response to horse ATG and rabbit ATG, when we compare the ATGs, horse and rabbit ATG, the overall survival is 96% in the horse ATG group versus the 76% in the rabbit ATG group. And the increase in blood counts in patients with hematological improvement is better with horse ATG when we compare with rabbit ATG. At 3 months, the response rate for horse ATG is around 62%. For 6 months, it is around 68%. But it is much lesser for rabbit ATG. It is 33% at 3 months and 37% at 6 months. Next slide. So when we compare horse ATG versus rabbit ATG, there are multiple studies that have confirmed that there is a better response with horse ATG in the form of the survival rate at 2 years is 56% for rabbit and 78% for horse ATG. And around 39% survival for rabbit versus 72% for horse ATG after censoring for stem cell transplantation. So approximately 50% response rate to upfront rabbit ATG at 6 months are seen, which are much lower than the historical controls are 75% for the horse ATG. And in another study, again, it is 50% for the rabbit ATG at 6 months when compared with the historical controls. Next slide. So after we give ATG, what is the durability of response? So approximately 50% of the probability. So if you see in the graph, the occurrence of late events like relapse or clonal evolution occurs over the period more likely after the 5 years post ATG. And high risk evolution to monosomy 7 complex karyotype, high-grade myelodysplasia, or transformation to leukemia occurs in approximately 10% of the responders over long term. 95% survival in 10 years without late event, and those with late events, the survival is around 65%. The survival was worse with the high-risk clonal events. Next slide. This slide basically compares immunosuppressive therapy and human ATG, horse ATG comparison of the responses. So when we compare them, you can see at 6 months, usually the response is around 43 to 50%. At 12 months, around 50 to 60%. And around 24 months is around 68%. Next slide. When other agents were added like to this ATG or cyclosporine regimens, there are multiple studies which try to add different agents to this protocol, but most of them failed. So they tried to add GCSF, danazol, MMF, sirolimus like that, but none of the studies showed any difference in the response or survival in these cases. Next slide. Next slide. When we go for the Indian experience, so this is the study by Dr. Sandeep Shah. So they studied the 91 aplastic anemia patients. They were given standard 40 milligram per kg of the dose of ATG along with cyclosporine. Next slide. So when we see at 3 months, the response rate was 41%, 6 months 48%, 12 months 56%, and 24 months the response was 68%. When the results were seen at 2 years, the complete response rate was around 23.5% for adults and around 39% for children. 2 patients have clonal evolution and the mortality was 51%. Next slide.
Dr. Vinod, sir, a great presentation, but you need to conclude in next 2 minutes.
Yeah, sure. So when we see the aplastic anemia cases in children, next slide. There is no difference in the outcome among the brands of ATG, ADGAM and Thymogam. Both have comparable results. Overall survival is around 3 years. For 3 years, it is 64% versus 62%. Next slide. For elderly people, the decision points are basically depending on the following points: the severity of the disease, the presence of comorbidities, and willingness of the patient and family members. So if they want to go for immunosuppressive therapy or not. Next slide. This is again the similar slide. Next slide. Next slide. Yeah, now this is one of the study of which is a French trial. Next slide. This was a trial which showed response to ATG in elderly patients. So what they saw was at first line therapy, 32% patient had complete response, 15% had partial response. So around 47% response rate was seen, and 3-year survival was around 74%, even with the median age of 68 years. Next slide. This is another trial. Next slide. So the response rate at 6 months in that trial was 68%, and at 12 months follow-up, the response was around 54%. Next slide. Next slide. So in this slide, we can see the cyclophosphamide was tried in these patients, but because of higher toxicity and lesser response, it is not recommended. Next slide. L-Trombopag, definitely it is a good drug now available for aplastic anemia patient, which was covered by Dr. Mukesh. Next slide. So higher survival rates are seen with ATG and L-Trombopag. Next slide. So when there is comparison between L-Trombopag with immunosuppressive therapy and haplotransplant, we can see the overall survival were comparable with haplotransplant when it was compared with L-Trombopag and immunosuppressive therapy. Next slide. So to conclude, the choice of treatment basically depends on the severity of the disease, age of the patient, and HLA match donor available or not. So current standard of immunosuppressive therapy is horse ATG, and immunosuppressive therapy is recommended for non-severe patients or very severe patients who don't have any more than 35 to 50 years of age. And there is no role of cyclophosphamide currently. Addition of third drug like GCSF, MMF or sirolimus have no any specific role. Substitution of horse ATG by rabbit ATG or other ineffective. Strategy for stem cell stimulation with L-Trombopag is more successful than any other approaches till now. And long-term follow-up and different combinations and other drugs that can be added that has to be seen in future. And also long-term follow-up of Trombopag with various suppressive therapy has to be seen in future. Thank you. Next slide. Yeah, thank you. So there is another slide actually. This is from the Bharat Serum. We all know that aplastic anemia management is very difficult because there is no much support from the government or other yojnas for those patients. So to give treatment in the form of ATGs is very difficult for these patients. So now Bharat Serum has come up with the program. Next slide. ATG, of course, there is the issue with the affordability because of cost. Most of the patients are not able to take ATG. Next slide. So this is first time in India, Bharat Serum has taken an initiative and they have launched this program called Aplastic Anemia Support with Holistic Approach. You can approach Bharat Serum for this program. Next slide. Next slide. This is the number where you can contact them for your patients who are not able to support for ATG. Next. So patient counseling, patient assistance, and financial assistance can be provided through this ASHA program. Thank you.
Hello. Hello.
Yes, sir.
Yeah, thank you, Dr. Vinod Patil. I think we can't hear Ajay. There is a problem with the audio. Ajay, are you there or? Okay. So, and since we are past time, so I take the liberty of inviting the next speaker, who's Dr. Rajat Bajaj, and he'll be talking to us about role of antifungals in aplastic anemia. All of us are aware that patients with aplastic anemia are at long-term risk of developing several kinds of infections. And let's see what Dr. Rajat has to tell us. He is a consultant hematologist and bone marrow transplant physician at HCG Manavata Oncology, Nashik. Dr. Bajaj.
Good evening, everyone. Am I slide visible and am I audible?
Yes, please.
So thank you for the kind words, sir. Thank you to the organizing team for giving me an opportunity to speak today. So I'll be quickly speaking on the role of antifungals in aplastic anemia. So we are all aware of the pathophysiology of aplastic anemia, that the unknown antigen presents antigen to the antigen presenting cells, which activates the naive CD8 T cells, leading to expansion of CD8 T cells, cytokine release, and apoptosis of the hematopoietic stem cells, leading to pancytopenia. So aplastic anemic patients have a pancytopenia, very low white cell count with knocked T cell function. So it makes a fertile ground for all the fungal infections. However, so a couple of decades ago, when aplastic anemia used to be considered as a fatal disease, after the development of ATG, the responses started improving. However, there was still a lot of mortality given the fatal fungal infections. So as you can see, back in the 90s, the mortality due to fungal infection was as high as 30%, whereas it has now come down to 3 to 5% in the era of newer antifungals. So before going on to the antifungals, let's go through some definitions. What is a proven invasive fungal infection, which has got a histological or evidence on culture in sterile material of demonstrated fungus? Probable invasive fungal infection is the one wherein there are host factors contributing to fungus. There is mycological criteria, and there is culture positivity on a non-sterile material, plus a high clinical suspicion. And possible invasive fungal infection is the one where there are a lot of host factors with clinical suspicion. However, even if this criteria are not met, patient may still have an invasive fungal infection. Now, what are the fungi which we commonly deal with? One are the yeast and then the molds. The yeast commonly include the Candida and the Cryptococcus. The molds include the aseptate and the septate fungus. The aseptate, the most common and the lethal one which we encounter is the mucormycosis. Amongst the septate fungus, we have the Aspergillus and the Histoplasma, which are commonly seen. Now, what are the criteria for a proven fungal infection? For molds, it is microscopic analysis by histopathology or cytology, culture on sterile material, and blood culture positivity, and nucleic acid amplification by a DNA PCR. And for the yeast, we have the microscopic analysis, culture on the sterile material, or blood culture positivity. Serology is not very useful except for Cryptococcus, where antigen detection can be done. So what is the distribution of these fungal infections? So back in the 90s, the Aspergillus was the most common, followed by Candida. Likewise, the incidence is similar nowadays. The Aspergillus accounting for 60% of all fungal infections, followed by Candida, which accounts for 25%. And the rest, 10-15%, are found by the other fungi. Now, what is the impact of Aspergillus? It is the most common mold infection. It is airborne and entry through nasal passages. The incidence of Aspergillus in severe aplastics and very severe aplastics is in the order of 4 to 9%. And however, the mortality has significantly reduced in the era of newer antifungals. The most commonly affected organ is the lung, where there is a characteristic halo sign, which is a nodular lesion surrounded by an area of ground glass attenuation, and an air crescent sign, where there is a nodular lesion with an internal necrotic cavity. As far as Candida is concerned, it is more commonly seen in hematological malignancies, not so common in aplastics. In India, the Candida tropicalis is more than Candida glabrata, and a lot of resistant candidial species are coming up because of increasing use of fluconazole prophylaxis. Most common of which is Candida auris, with a mortality with a very high mortality rate of around 30%. We are all aware of the horror which mucormycosis can cause. Highly fatal fungal infection usually causes rhinocerebral pulmonary disease and CNS disease. The risk factors associated is chronic immunosuppression and the use of voriconazole. Now, why is the diagnosis of fungal infection difficult? One, because there is less suspicion. However, for practicing hematologists, fungal infection is always high on the cards, and there are no effective or easily available serum biomarkers which are available. This makes the diagnosis difficult, leading to a higher mortality. Now, what are the diagnostic tests which we have? First is the galactomannan assay, which is used for detecting molds, most commonly the aspergillus. It has got a good sensitivity, and especially if done in lower respiratory tract samples. However, the disadvantages are it's not very specific, and there are a lot of false positives. Next is 1,3-beta-D-glucan antigen test. It detects Candida and Aspergillus. Again, the disadvantages are it has got high false positives, and sensitivity is lower in patients who've got a localized fungal infection. PCR assays, they are highly specific and sensitive. However, there are no pan-fungal assays available. However, commercial labs are now coming up with multiplex PCR assays for detection of fungal infections. Now, what are the properties of an antifungal which is important to a clinician? One is the spectrum of activity. It should have low toxicity, patient-compliant dosing, less drug interactions, and it should have a broader therapeutic index. And of course, the cost should be low. Now, this is the timeline of development of antifungal agents. First came the amphotericin in the 50s and 60s. Then came the first generation azoles, including the fluconazole, itraconazole. And now we've got second generation azoles and echinocandins, which include voriconazole, posaconazole, and the echinocandins, which include caspo, mica, and anidulafungin. Mechanism of action, the polyenes or the amphotericin, they act on the cell membrane. So they're effective against most of the fungi. Next is the echinocandins, they act on the cell wall. So they're effective only in the fungi which have got an effective cell wall. Next is the azoles, which act on the ergosterol. So effective against most of the fungi. Let's see the spectrum of activity of all the antifungals. First is the amphotericin B, which has got moderate activity against all the fungi groups. Posaconazole, again, active against almost all the fungi groups. Isavuconazole, which is again a newer molecule, not very easily accessible in our country. It has got activity against almost all the fungus groups. Whereas the echinocandins, they are very highly specific for the candidial species. Drug interactions, amphotericin B, a very difficult drug to use. It's got a lot of nephrotoxicity, infusion-related reactions, and dyselectrolytemias. Azoles, again, it has got they are hepatotoxic, and they've got a lot of drug interactions because they are CYP450 enzyme inhibitors. Echinocandins, they've got relatively fewer interactions. However, they can cause some amount of infusion-related reactions and dyselectrolytemia. Now, how do we risk stratify our patients of aplastic anemia? There is no consensus how to give antifungals in aplastics. However, we can extrapolate the data from malignancies to our aplastic anemias. The patients who've got prolonged neutropenia, less than 100 count for 3 weeks or less than 500 for 5 weeks, are high-risk patients. Patients who've got a white cell count of 100 to 500 for 3 to 5 weeks with fungal colonization at one site are high intermediate. Patients who've got neutropenia of less than 3 weeks are low intermediate. And if the patient does not fit into any of these, then he is low risk. So why do we need to risk stratify our patients? To decide on our antifungals. So for patients who are high or intermediate high risk group, prophylaxis is recommended. For patients who are intermediate low or low, we need not give the prophylaxis, and only preemptive treatment may be initiated, and empirical treatment may or may not be given. And for patients who've got a proven fungal infection, irrespective where they fall, they need antifungal treatment. So primary prophylaxis is done for patients who've got neutropenia of more than 7 days and who have not had any fungal infection. So this can prevent fatal fungal infections. Secondary prophylaxis is given for patients who are anticipated to have neutropenia of more than 2 weeks and who have already undergone treatment for an invasive fungal infection. Now, which are the drugs which are useful for prophylaxis? So this is a comparison between first and second generation antifungals. So clearly the odds are in favor of the second generation antifungals, and there are fewer probable and proven fungal infection with second generation azoles, which is the posaconazole and the voriconazole, and these patients received fewer empiric antifungals after prophylaxis with second generation. Comparing azoles to echinocandins, there is clear-cut difference between the azoles as far as prophylaxis is concerned, and echinocandins are hardly used for prophylaxis, and they are associated with higher incidence of breakthrough invasive fungal infections. Coming to liposomal amphotericin B, so the studies show the incidence of invasive fungal infection on lipoamphotericin is 8% as compared to 12% in the placebo group. The overall mortality is also similar. So liposomal amphotericin is not very effective as prophylaxis in invasive fungal diseases. What antifungal prophylaxis is to be given as per the specific fungal prophylaxis? For Aspergillus prophylaxis, azoles remain the drug of choice. Posaconazole has got a better quality of evidence as compared to voriconazole. For Candida prophylaxis, usually there is no prophylaxis recommended unless the patient is very high risk or the patient is in the ICU. There is some data on fluconazole or echinocandins being used as prophylaxis for Candida. What about mucor prophylaxis? So nothing really works for mucor prophylaxis. There is very low quality of evidence as far as even the IV posaconazole or the newer isavuconazole is considered. Now, which patients need the preemptive or empirical therapy? Preemptive therapy is usually diagnostic driven. If there is a serobiomarker which is highly suspicious of a fungal infection, and the patients who are at risk may need preemptive treatment, and empirical treatment is given for the patients who have got low neutrophil count, less than 500 patient, and who has got high clinical suspicion. It is not usually dependent on serum biomarkers. So what are the treatment options for preemptive treatment for patients who are already on an azole or lipoamphotericin prophylaxis and who've got clinical symptoms suggestive of an invasive fungal disease? So we need to go ahead and do confirmatory tests like blood cultures, HRCT, and serum biomarkers. If the drug levels are adequate and there is no invasive fungal disease, we continue the same prophylaxis. If the drug levels are low, no fungal disease, we increase the drug dose, repeat a drug monitoring level, and if therapeutic range is not achieved, we change the drug class. If on all these prophylaxis there is an invasive fungal infection, then we change the class of drug to the specific drug. Empirical treatment is for patients who are not on prophylaxis, or patients who are clinically unwell, or patients who are on prophylaxis and have got suspicion of fungal infection. We go ahead and do the specific test, which include a CT scan, blood culture, and galactomannan PCRs. If the invasive fungal infection is detected, we continue the empiric antifungal therapy and change to targeted therapy according to the culture on susceptibility testing. If there is no invasive fungal detected, we can de-escalate to prophylaxis or stop therapy if the patient was already not on prophylaxis. Now, if we have a proven
Dr. Bajaj, sir, can we request to conclude, please? Last 1 minute for you.
Yeah. So if the patient has got a proven infection, invasive aspergillosis, first line of drug is voriconazole. An alternative can be amphotericin or isavuconazole if voriconazole is contraindicated. This was the IDSA guidelines. The ESC MID guidelines also suggest the same, isavuconazole or voriconazole as first line. Likewise, the ECIL6 recommendations are also for voriconazole or isavuconazole. And isavuconazole may have a better safe toxicity profile as compared to voriconazole. However, the efficacy remains the same. Likewise, for candidemia, the first line of treatment is echinocandins. Alternatively, fluconazole can be used for patients who are relatively stable. And likewise, the ECIL guidelines also suggest the use of caspofungin. Caspofungin, enidulafungin, or micafungin. As far as the species are concerned, almost the echinocandins are effective against almost all the species. Mucormycosis, horrible fungus infection to treat. However, it needs a multimodality approach, surgical debridement followed by immediate treatment with an antifungal. The drug of choice is lipoamphotericin, which has got a better safety profile. If the patient has a CNS involvement, higher doses of 10 milligram per kg per day may be required. So to conclude, to treat a fungal infection, a hematologist needs to have a high suspicion. Each patient may need tailored treatment, and with the availability of better diagnostic techniques, the mortality has come down. As far as aplastic anemia is concerned, prophylactic antifungals are to be used only in patients who have got a very severe aplastic anemia. Voriconazole or posaconazole, they appear to be more effective than fluconazole, as they have activity against Aspergillus and also some other mold species. Antifungal prophylaxis should also be considered during the first months after ATG therapy and for patients who are taken for transplant. Thank you.
Thank you, Dr. Bajaj. So, is Dr. Ajay available to call the next speaker or?
Okay, no, I was wondering whether, because as per agenda, it mentioned your name. So thanks,
No.
sir.
I think
So,
I did
yeah.
your job, so now you can call.
Okay, sure.
Yeah.
So it's a great pleasure to invite Dr. Tulika Seth for the next session. As we all know that she is the professor in Department of Hematology in All Institute of Medical Sciences, and she's director of the Genomic Medicine Gap Health Foundations India. She's going to talk to us on remission in ITP with TPO agonists. That's a very evolving and very versatile spectrum of this drug. So she's going to talk to us on this topic. Dr. Tulika, I welcome you once again.
Thank you. Thank you so much. I hope my slides are visible and I'm audible.
Yes, ma'am.
Thank you.
Yeah, we can.
So I would like to thank the organizers and the chairpersons for this wonderful event. And the topic I've been assigned today is TFR with TPO agonists in ITP. So for this august audience, we all know what primary ITP is. And so I won't go into that in detail. We know that in India, it is fairly common, though we don't have exact data. It's more common in children than in adults, but in older adults, we again see a large burden of this. The patients with ITP, not only do they have bleeding problems, but they also have a lot of quality of life issues with fatigue and anxiety and bruising being the major symptoms. We do need to treat these patients because of the symptoms and the risk for bleeding, and we need to tailor the therapy according to many factors, including the bleeding risk, the patient preference, the cost of therapy, etc. And we have special goals of therapy, which is mostly in chronic ITP to keep the platelets at a safe range so that the patients can be less symptomatic with bleeding and they can have less toxicity from the therapy. The better understanding of the mechanisms leading to ITP have been able to create several newer targets. We now know that ITP is not only destruction of platelets, but there is also a relative reduction in the production of the platelets as well. And this has led to, again, as I said, several new targets. And one of the very important groups that we are able to use for treatment are the thrombopoietin receptor agonists. So of which at present we have two of the TPO receptor agonists. One is L-thrombopag, which is an oral tablet, and it has several precautions that we need to take in regards to meals. And the studies of this showed that it was very efficacious and safe, and the usual dosage recommended for adults is about 50 milligrams, and it can lead to sustained improvement in the platelet counts in not only adults, but also in pediatrics. And there are guidelines for dosage adjustment because we don't want the platelet count to be too high because of complications that can occur. Romiplostin is the other TPO receptor agonist, which is available in India. And this is a subcutaneous injection, which is given once a week. And again, this doesn't have any homology with the endogenous TPO. And these studies have shown that, again, this once a week injection is able to maintain and sustain the platelet count. And we do dose titration, either for patients who don't have a good response or for patients where the response is inadequate. We can add an immunosuppressant or we can increase the dose. And again, if the platelet count is very high, we can reduce the dose and modify. The agents are very important because not only do they give good response with less side effects, but they have also been able to improve the quality of life, particularly the fatigue component, which was not addressed by other treatments that were available. And this is one of the reasons why, because of the importance in the quality of life studies, that these agents have now become very important in our armamentarium for treatment of ITP. And in most of the guidelines, like the ASH and European guidelines, these are now the second line treatment for patients. In India, initially, we were a little slow to use these agents because we had the innovator in L-Thrombopag from back in 2011. But now with the generics of both of these, the Romiplostin and L-Thrombopag, which have been approved, we have now been able to expand this use to many more patients, and the cost is no longer such a limiting factor. So as I said, both of these agents are approved in second-line therapy, and they are effective and safe and useful. Long-term use of these agents has shown that the adverse events are there, though most of the adverse events are not too much. So we know that patients can have thrombosis, there may be rebound thrombocytopenia, there can be hepatotoxicity with L-Thrombopag, and the venous thromboembolism risk is there with both of these products. It's about 6% with L-Thrombopag and about 6.5% with Romiplostin. So, and this has been studied in great detail. So now that we know that these agents, though they're safe and effective, do they need to be continued forever? That has been raised. So one of the other problems is the interactions with food, again, making it difficult to sustain in the long term. And often when we see loss of response, we find that patients, particularly with L-Thrombopag, have not been taking their medicine as recommended. And this is a summary table showing the risk of complications with both of these agents. So we know that even though they are safe and effective, we would like to be able to avoid using them in a long term. The goals of therapy that we have are to keep the platelet count at a safe level and to avoid bleeding. But the goal of cure is always been there. And we know that currently only with splenectomy are we able to achieve cure. And with the TPO receptor agonist, the thought was that could we cure these patients? So there is now some emerging data in which it was found back in 2013, in fact, that patients who had been on either of these TPO receptor agonists for some time, some of the patients after stopping of the drugs, they were able to sustain the platelet count. So this interesting finding was noted and people evaluated it. And what this is a summary table of 3 of the TPO receptor agonists. Avatrombopag we don't have in India, but again, it was found that the response rates were very good, and these patients, some of them could go on to have a cure. So that comes up to the topic of today, which is what do we do with these patients and how can we achieve a cure? So in 2015, there was an ASH abstract which evaluated L-Thrombopag, and it questioned whether patients could successfully be tapered off this product and whether they would be able to sustain their response. And the question was raised because they wanted to know if this had to be an indefinite therapy or could this be a therapy that could be discontinued. So they evaluated patients who were willing to be discontinued, and these patients had to have a target of 50 to 100,000 platelet counts. And they initially, many of the patients were on 75 milligrams for at least 4 months. And then they started to slowly taper over 2 years. So this was a very slow taper that was done, and it was done at every 4 weeks. 10 to 20% of the dose was done. And they were able to find that there were about 30% of the patients, because there were about 32 patients on this trial, 30% of them were able to, once they were off the drug, they were able to sustain their platelet count of more than 50,000 without any other rescue medicines. So this was very interesting, and this basically shows these groups of patients who were able to maintain the platelet count. Though of course some of the patients, they did relapse and had to go back onto the platelet count, go back onto the platelet medications. So this was one of the first studies that really looked at this. In romiplostin also, this was evaluated, and we know that patients can have a good response with romiplostin, and some of the patients can go on to be tapered off. And this was a study that was done where they slowly reduced the dose of the romiplostin in patients who had a good response above 50,000. And then there were patients, again, about 30% of the patients who were able to maintain the platelet count at about 50,000 without any further medication. So they also had a treatment-free remission. Now, to evaluate this in a larger way, this is a very recent publication that has come out where they did a study of hematologists in the UK to find out what was their practice and what was their experience in the real world with treatment-free remission. And they did a Delphi model questionnaire where they sent out questionnaires to many of the hematologists and hemato-oncologists to find out what was their experience in practice of using the TPO-RAs and about tapering and discontinuation and reinitiation in the patients who had a poor response. And these questionnaires were sent out to a very large number of hematologists, and most of them had been in practice for a long time, and the majority of them were in academic or teaching hospitals, and they mostly spent their time taking care of patients. And then they had patients who had were either on L-thrombopag or romiplostin. And the study showed that about 30% of the patients of these hematologists were suitable for tapering or discontinuation. And of these, some of the patients did require, so out of the 30% who were tapered, again, about 1/3 of these patients required reinitiation. And then after these interviews were done, there was an ITP expert consensus in which the patients in which people looked at all the data, and then they gave some guidelines. So what the expert panel did after evaluation of the guidelines were that they felt that it was important that tapering and discontinuation of TPO-RA could be considered for certain patients. The experts agreed that the tapering should be considered after about 6 to 12 months of therapy. So just giving a few months of therapy is not ideal, and you need to evaluate the risk of bleeding. So for example, if you have an elderly person who's had a fall, probably that's not the time to do the tapering. And you need to make sure that you have a stable platelet count of more than 50,000. And this should be something that was steadily there for the majority of time in the last 6 months. So if you have patients where they keep fluctuating, again, it's not the right time to do it. The tapering, the expert committee felt should be done slowly. And if the platelet count was less than 30,000 after tapering or discontinuing, then you need to do a watch and wait approach to decide what to do, whether if there's bleeding or if there's other problems, then you can make a decision, because there are some natural fluctuations. So just because the platelet is 30,000 doesn't mean you have to restart. So it's important to counsel the patients not to panic and to evaluate these patients over a period of time. They looked at many factors like age, the duration of ITP, what was the current dose of the TPO-RAs, and many other factors like comorbidities and concomitant medicines. But unfortunately, they were not able to find any predictors of patients who were suitable or for TFR. So at the moment, we don't have any standard guidelines except that patients should have a platelet count of more than 50,000, which should be stable for at least 6 months. The other things that the expert panel said that we need to look at the individual differences and patient preferences. Obviously, if you have a patient who is on antiplatelet medications, for example, or has any high risk for bleeding, then, or is a very anxious patient, then again, you need to decide whether they are candidates for TFR. So as I said, at the moment, we don't have any clear predictors to identify the patients who may in the future be suitable for TFR. When you're deciding to taper or discontinue, you must look at all the factors like the age, treatment, and disease duration. There may be some situations which may not be appropriate, especially if patients have had life-threatening bleeding, or if they are patients who may not be able to access effective rapid rescue therapy. The halting or of the taper and reinitiation may be considered if the platelet count is less than 30,000, or if the patient experiences bleeding, persistent worsening of quality of life, anxiety, fatigue, etc. For patients who discontinue TPO-RA, reinitiation may be considered again, either if the platelet count decreases or if they develop symptoms. So what the algorithm recommends is that you give the TPO-RA treatment for at least 6 to 12 months. And then if the patient has a stable count for the majority of time, more than 75% of the last 6 months where the platelet count is more than 50,000, these patients may be considered for discontinuation if they don't have any other risk factors. And then you can decide if after tapering and stopping, if the platelet counts are low or if they have bleeding, then you can reinitiate the therapy. So I think this is pretty much what we are also doing in our practice. And we've also felt that about 20 to 30% of patients are able to maintain their platelet count, especially if they've had the TPO-RAs for about 1 or 2 years. So we still need to have, there are still some questions that are there. We don't really know which are the predictors of this. We're not sure if all the patients, what individual factors we need to take. The reinitiation obviously needs to be done whenever the patients become symptomatic. Whether the patients will respond or not is something that we're not still sure about. But one of the things that they did talk about was that it's a good idea to try to do a TFR. The other advantages of a TFR is that the patient gets a treatment holiday. We know that majority of times the patients can be monitored safely, and and if these patients are lucky enough to get a remission, then they can be off their medicines for a time, which will definitely save cost and have a lot of other benefits for these patients who otherwise may feel that they are suffering from a chronic disease. So this is an interesting new concept, and the TPO-RAs are amongst the other agents that we have. Now, we really didn't have anything that could offer us a cure except for splenectomy and a few subsets of patients like young women who had had ITP for less than a year who may respond to rituximab. So this is another option that we have that can be utilized. To summarize, TPO-RAs are effective second-line agents, and TFR is possible in about 30% of patients, though some of the questions are still there about who and how, but a trial of TFR can be done. And I think this would be something that we can collect Indian data, and it may be different in our Indian patients because we often use the TPO-RAs as a third or fourth line rather than as a second line. So thank you very much.
Thanks a lot, Dr. Tulika, for this wonderful synopsis and overview of the management of ITP in general in today's scenario. Thank you very much. And as ever, It was a very wonderful talk, and together with Dr. Subhash Verma, my co-chairperson, I thank you once again. Thank you very much. With that, I think we are at the end of this session, and I hand it over back to Dr. Ankur and his team for continuation of the session further ahead. Thank you very much.
Thank you, sir. Thank you, Sharma sir, and thank you, Verma sir. I am really honored to pay my regards and the thanks for joining this session, and to all my eminent speakers. So now we have our next session, that is the chronic lymphocytic leukemia, strategies for optimal patient care. For this session, I would like to invite the eminent chairpersons. The chairpersons, they don't need any introduction, but still, this is my duty to introduce them. It's a Dr. Pankaj Malhotra. He is professor and in charge of Department of Clinical Hematology, PGI Chandigarh. And Dr. Suparno Chakrabarti, he's head and the Department of BMT and Hematology from Dharamshila Narayana Hospital, Delhi. Over to you, sir.
Okay, thank you for inviting to chair this session. So on behalf of my co-chairperson, Dr. Suparna Chakrabarti, I invite the first speaker, my good friend and colleague, Dr. Joseph John, who would be speaking on role of ibrutinib in CLL. Joseph, please.
Thank you, Dr. Pankaj. I'm just sharing my screen. Just give me a minute, and that's it. Okay. I could not send my presentation earlier. Sorry for that. Thank you for this session, and it is nice to catch up with the hematology group in Punjab and other places, and from Mumbai it is being hosted. So today we are going to talk about ibrutinib, and I would like to start with the theme of know your weapon. So we all have various kinds of weapons which we use in CLL. And this is the first in class of the weapon, and we need to know all about it. I'm not going to be exhaustive, but only the practical aspects I would like to discuss today. I would say ibrutinib is the imatinib of CLL. We got something in 2002 that is repeated into 2020. So 2020 was good for CLL. Just to give you a fact fun, CML has become CLL. And M in Roman is 50, L in Roman is 1000, and therefore 2002 to 02 is turned around to 2020, and when you turn around 1000 to 50, that is 20. I don't know whether it is coincidence or it happened just like that or some divine intervention. Whatever it is good. We have the new molecule imatinib of CLL, which is ibrutinib. So that's his siblings, which have been born very quickly. Like imatinib had only about 4 or 5 siblings coming out now. This one has 6 more siblings, and we'll be hearing about them from the subsequent speakers. So that's a weapon we have. Maybe the AK-47. The B cell receptor signaling. So all about is B cell receptor signaling. So we have a B cell. On top of that, we have a CD79A and a B, which will then subsequently is giving a cascade of receptors and molecular targets which are taking it down. One of them being our Burton receptor tyrosine kinase. So that's a crucial terminal kinase enzyme for the BCR signaling pathway. Now, if you go back into the numbers, it is very interesting how this was discovered was X-linked A gamma globulinemia. So basically somebody's misfortune and the scientist's inquiry to find out that a rare disease, a scientific inquiry subsequently led to a BTK inhibitor. It is not only hematology, but it is being avidly being explored in solid tumors as well. So obviously we understand that this BTK is a component for proliferation and apoptosis. If it can be prevented, apoptosis can happen. So there's a whole myriad of downstream pathways which happen. We do not have the time and the capacity or the bandwidth, so to speak, to understand this downstream cascading. But we understand that if we do BTK inhibition, we know. Now, this insight has come from Burton tyrosine chemistry, gamma globulinemia, and there is another immune deficiency entity called PI3 kinase, PI3K mutation, and problems regarding to lymphoid proliferation. So, a lot of things are in store for us as we understand more and more of these downstream pathways. So, essentially, if you can irreversibly inhibit the Burton tyrosine kinase, the B cells are then not allowed to proliferate and they can be knocked off. And that's what we are going to harness when we use ibrutinib. So that's the list of FDA approvals, and there are so many to follow, I would say, from CLL to mantle cell. In fact, mantle cell came in first, and then marginal zone and Waldenstrom and chronic GVHD. We will just take a whiff of to understanding our weapons. 2013 is mantle cell and 2020 was untreated CLL. It was being given for relapsed refractory, and the real game changer happened when it was approved 6 years later in untreated CLL or naive CLL. So that's the gold standard for the US FDA versus EMA and what we are in India, which is being seen. So when you look at the Johnson & Johnson and oncology revenue share, so you must understand how ibrutinib has changed the world, like imatinib, which has changed the world. So if you look at the revenue share from 2011 onwards, this green is ibrutinib. And that's a share market which has grown along with Darzalex. The ibrutinib share has also gone in. And that is what we are seeing in Indian companies also. The ibrutinib is coming. So many the controversies in the court. It was a similar story was there in imatinib, and yet the Indian market found a way to do that. I'm happy about it. Nothing against Johnson & Johnson or any other company, but I would say that the more the merrier, the players, better it is. So because earlier at some point we used to say that we should have a water supply of venetoclax to all hematology wards, because seems to be there indicated in all the patients in hematology. Similar thing might happen in ibrutinib also in the coming to time, but acalabrutinib and the other ones are better off than this. Just a word on mantle cell lymphoma. We use about 560 as compared to 460 milligram in the other, and it can be given in combination with venetoclax also. Waldenstrom's is at 420, marginal zone is 560, and chronic GVHD is at 420 or 250 milligram per meter square. That's the story of ibrutinib in India. India, it is now for CLL, SLL, untreated and relapsed refractory mantle cell. So far, the mantle cell lymphoma upfront, it does not yet come. It is still the DAP and the R-CHOPs, which are the gold standard right now. If somebody can, can tolerate it. Waldenstrom, of course, it has come in as first or second line therapy. Second line onwards now we are using mantle cell, marginal zone lymphomas and chronic GVHD even after it is after one line therapy also. So CLL and lymphocytic lymphoma is what we focus on, and that is what we need to understand. And I'll give you 4 main studies for us to take home after this discussion today. Before going to that, I would like to say the practical aspects of taking this medicine. It is not like nilotinib or eltrombopag. It can be taken as a whole. It should not be broken though. It can be taken along with food also. Disregard of the food, you can take it. Renal failure, the studies have been that if it was to be more than 25, no dosage adjustments otherwise. Hepatic impairment also. Hepatic impairment, there is a problem with regarding to that, and you must reduce the dose. And I don't think anybody can remember this, but at least understand that it is being excreted through the kidney, through the liver, and therefore we need to look up the literature along with that. Adverse reactions are one of the things we need to be very careful about, especially bleeding issues. Somebody who's on aspirin, chances of bleeding symptoms are likely to go up. Somebody who's got a DCM or a cardiac dysfunction in the past, the chances of cardiac arrhythmias are high, atrial fibrillation or atrial flutters are more. So therefore, we must do a baseline ECG tell the patient that you may get palpitations. If you get palpitations, stop it. One of my patients had extreme somnolence, and in fact, when we brought it down to 140, things came better, and it was giving a reasonable cell count control also. As Pankaj would agree with me, that there is a publication from PGI about a reduced dose of ibrutinib in CLL, and still we can reach the target there. As we understand, our surrogate endpoint is PFS, and our hard endpoint is OS, and OS is usually not changed much in CLL with any of the interventions. However, this has some bearing in it. And of course, at a lower dose may invite latent relapses or progression more than 420, but at least it won't be as expensive as the full dose. If there are bleeding related events, we must stop it. And because we must have a possibility of the bleeding, we must be cautious before the surgery. So that's something which we need to watch out for. And some of the patients may come back with hematomas or purpura, and that time we should be ready with the plan. So that's the journey of imatinib dose. And if you have a toxicity, stop, restart at a lower dose. So when you restart, you can restart at the original dose. And then if you have more, now there's a Bayesian philosophy coming in. The priors will guide the posts. Okay. So then if you have a second event, it is 280. The third event, you go to 140, and then you stop it off. So that's the journey for a patient in terms of optimal treatment titration, baseline evaluation. We call them after a month usually to see what's happening, or inform us with the reports. And if there is clinical benefit and no adverse events, stay on course. And this is a drug we need to watch out and say that this is going to be a long term, and that's something which we need to keep talking to the patient, that we're converting something like this to a hypertension and you need to continue for long term. The current evidence is about 8 years. That's a real world evidence. I'll allude to that in some in coming slides. So these are some of the studies we must remember. And I wouldn't go too much into the previously treated groups, but we will go into the resonate to illuminate and one more study which I will show you, where we want to talk about treatment naive. So few studies, if you remember the word resonate to illuminate, it is for previously untreated. So that's the 8-year follow-up study for this phase 1 8-year follow-up study, which shows the progression-free survival. That is a PFS of a marked difference between the two. This thing, median PFS is not reached in 95% of confidence interval with the first line versus 52 months in the other groups. So that's the 7-year PFS is 83 with 83 versus 34. Let me correct myself. This study which I'm showing is a relapse refractory. So that is the relapse refractory group, this study which we have come across. And we need to remember a few studies I will come across to that, saying that the PFS is markedly different in the two groups. Now we are taking the treatment naive groups. So we take the Resonate study, the Illuminate Alliance, and ECOG. So 4 studies upfront. First time we are comparing with ibrutinib with chlorambucil. Second study, ibrutinib and obinutuzumab, and then obinutuzumab with chlorambucil. So we are adding the effect of obinutuzumab, whether it will nullify the effect of ibrutinib or not. Alliance is a 3-fold study. Ibrutinib alone, ibrutinib and rituximab, and bendamustine rituximab. And the last one is ibrutinib, rituximab, and FCR. Let's evaluate them just by the last study of PFS. OS has some event, but this is where they are, the company and the paper is concentrating upon and show us. And this is shown that the median PFS in the chlorambucil is 15 months versus not reached in the ibrutinib arm, which had hazard ratio of 0.16. So this 84% times better than chlorambucil. When I look at it, it is a small knockout, a weak opponent, knocked out very fast. You chose chlorambucil to fight against. At least now ibrutinib is gaining confidence in the coming years, and it is now reaching the illuminate study. Whether we saying, okay, is it ibrutinib alone, or is it rituximab can nullify the effect and it can be along with chlorambucil, and that is got a good study, and the graph is reasonably well digressing along the way in the early months itself, and it is a hazard ratio of 0.25. That's 75% better. P-value is very significant. Confidence interval is not very broad, and it is a narrow confidence interval. So all well. This time it is 2 versus 2. Still, it has won. Obinutuzumab is not making a difference. Ibrutinib stands alone. Well and good. Next study is the phase 3 alliance study with again.
Sir, can we
PFS.
just request to conclude, please, Dr.
1
Joseph?
minute,
Sir,
1 more
can we
minute.
request to
Finished.
conclude, sir?
Finished. So this is 3 arms: ibrutinib with rituximab and bendamustine. This is again a 3-part. Again, ibrutinib stands alone. Whether it is added with rituximab or not, ibrutinib is the winner here. Last study to show with FCR, 3 guys against 1. Still, ibrutinib is the winner. Hazard ratio is wonderful, about 60%. 2 of them are taken on board, 1 again. So the take-home message is very simple. This is a first class in BTK. It has a once daily regimen without chemotherapy. Also, we can, prior chemotherapy, we can give it. Superior PFS of ibrutinib, long-term safety is established. Early use of ibrutinib is better. And the overall winner is ibrutinib. Over to the organizers. Thank you.
Dr. Suparna?
Yeah, hi. Yeah, thanks for inviting me. I would now request, am I heard? Am I audible?
Yes, sir.
Yeah, I would now request Dr. Abhay Bhave to carry on this discussion with another BTK inhibitor. Abhay is a very dear and old friend of mine from the early 1990s, and he, to me, is one of the most excellent hematologists that I know. He's spoken a lot on CLL, I've heard in bits and pieces. So I think he's the best person to take it forward. Abhay, please take the stage.
Thank you very much, Suparna. And I thank and also, hi, Pankaj. I'll take this opportunity to thank Ankur and Dr. Ashwin Phillips for organizing this meeting.
Thank you, sir.
So, Ankur, very proud of you, by the way.
Thank you, sir.
You put across a lovely meeting, and you've got fantastic speakers. And there's so much to learn from the preceding talks that have taken place. So thanks for letting me be a part of this discussion. So my task that you have given me, Ankur, is CLL strategies for optimal patient management. And I'm supposed to speak on acalabrutinib.
Yes.
So the treatment of CLL has changed remarkably throughout the past decade, with patients receiving more and more durable responses and deeper responses. And what is good to know is that those who had adverse prognostic factors or high risk, as we called it, cytogenetics, they also have started giving us good responses, which was not happening in the future. Now, we all know that in CLL, we've got a situation where about 1/3 of the patients will not need any kind of therapy. They'll be just kind of no-go. Then there are others who will be slow go, will need therapy as time goes along. And there are others who are aggressive, about 1/3 of them, who will show a rapid increase in the lymphocytes and will need treatment much earlier than the others. And they start off as a mild major B lymphocytosis, which keeps slowly increasing over a period of time till there's enough genetic accrual to cause them to become symptomatic CLL, at which point of time we give some form of therapy. And there invariably is a response, and post-response invariably there is a relapse over a period of time, because CLL as of now is still considered incurable. We had chlorambucil to start with, then we got FCR, which did a phenomenal service to us, especially for those patients who had the mutated heavy chain, where we saw functional cure in many of the patients. But it came with a baggage of issues like marrow suppression and infections, especially opportunistic infections, where we started losing patients to neutropenia and the disease was gone, which was extremely distressing. We are fortunate that we got the combination of bendamustine rituximab, which I think is the most widely used till the BTKs came in. And the newer therapies have changed the way we've looked at CLL. And one of the reasons is that unlike the other therapies, other than FCR for mutated IGHV, but the newer therapies are also giving up an option for getting undetected measurable residual disease, which is something which is most exciting in both CLL and in myeloma. So what we are seeing now in CLL is a change in trend. We are now looking at targeted molecules which are disrupting crucial pathways so that they don't survive or they don't proliferate, especially the malignant clones. We're now getting chemo-free combinations where there are combinations or single agents of either targeted therapy or monoclonal antibodies that can achieve deep remissions for a durable period of time. And the main game changers have been the BTK inhibitors. We've already heard Joseph John speaking very eloquently on ibrutinib, which has been really a real game changer in CLL. And thanks to the Indian pharma, we were able to get ibrutinib into the net of the common man. We also have acalabrutinib, a second generation BTK inhibitor. We've got venetoclax, which is a BCL2 inhibitor, and a monoclonal antibody, which is new. It is obinutuzumab, either alone or in combination. And these are very effective in getting improved remission, duration, and survival, including in high-risk patients. But one must remember one thing, that the natural history of CLL is variable. The patient's characteristics and intrinsic biology is also variable. Therefore, unfortunately, there's no one size which fits all. And therefore, we have to be very careful how we select our patients for therapy. So you've already been told about BTK, so I'm going to skip this slide. I just want to say that it is expressed on the B lymphocytes predominantly, and these BTKs are very important for the B cell development, differentiation, signaling, proliferation, survival. And if you inhibit them, then the cell will not survive. So we've got a small molecule BTKI, which has demonstrated a significant anti-tumor activity in B cell diseases. You must also remember that a large number of our patients are on the older side, with the median age in the West being 72, but with us being much lesser than that. And most of them would have some form of comorbidity that will make you think twice before writing a drug. And we know that these drugs, especially the BTKI, will be given on a long-term basis. Therefore, they should have the ability to tolerate it for a long period of time. You heard about ibrutinib, a great drug. All of us use it both upfront and in relapse state, either alone or in a combination, although alone has been the more preferred one. And you must remember that there are patients who will discontinue this therapy due to adverse events, about a fifth of them, and about a fifth also will require dose reductions. And in my practice, I know that to use ibrutinib in its full 420 milligram for CLL is really difficult. Most of the time, we are using lesser drugs. Now, we've got publications from across, from our country and from outside, that less is also quite good, and therefore we can still use lesser amounts and get away. What I don't know is whether lesser controls the disease, but will it allow the drug to become resistant over a period of time? The common side effects of ibrutinib that we have to worry are bleeding arthritis, atrial fibrillation, hypertension, an increase in lymphocytosis initially, then it drops down, infections, diarrhea, and headache. So these are the few things that I tell my patients, that please keep this in mind, because there's a chance you might have this. So do we have anything different that could overcome the side effects of ibrutinib? And sure enough, we've got acalabrutinib, which is available, highly selective, potent next generation BTK inhibitor, which has got a high selectivity for BTK. You'll notice over here that as comparison to ibrutinib, the off-target kinase activity of acalabrutinib is much lesser. Remember, the more number of families of the TEC, which BTK belongs to, the more number of families it affects, the side effects and the benefits start changing. And the more specific you are to a BTK inhibitor, the more is the benefit and lesser is the side effect. So the journey of acalabrutinib was from 2017, where it got approval for mantle cell lymphoma. And sure enough, the FDA approved it in October 31st, 2017 for MCL. And in another couple of years, it got approval for for CLL. Now, the basis of getting approval for CLL was the 2 phase 3 trials, that is the Ascend and Elevate TN. In the Elevate TN, there were 3 arms: acalabrutinib with obinutuzumab, acalabrutinib given till progressive disease, and this was compared to acalabrutinib alone till progressive disease versus the monoclonal antibody obinutuzumab with chlorambucil. Just remember that a crossover to acalabrutinib was allowed in this group over here, and therefore it's hard to say about overall survival. Therefore, most of these trials will have PFS as their primary endpoint rather than overall survival. And what we saw here was an unprecedented progression-free survival, where there was a 90% benefit of using acalabrutinib with obinutuzumab with a 90% risk reduction. And importantly, if you use acalabrutinib alone, then it was an 80% risk reduction. That means as a single agent, just like ibrutinib, acalabrutinib also does a decent job, I would say more than decent job, in giving a progression-free survival. And look at the age group, the sex, staging, ECOG performance, or whether it was bulky disease. Throughout, you will notice that acalabrutinib along with obinutuzumab gave us a certain benefit, and therefore it was favored as opposed to obinutuzumab with chlorambucil. And this was also seen in the risk stratification. So if we had high-risk disease or complex cytogenetics or IGH mutation status, again, acalabrutinib and obinutuzumab was the one which was benefited. And if you look at the side effects, the number of grade 3 side effects with acalabrutinib were not significantly high, except probably for neutropenia. But otherwise, it was comparable to the other 2 arms, except for the infusional reaction, which takes place with obinutuzumab, which usually happens in the first cycle. Thereafter, it's minimal. But most importantly, you'll see that as far as cardiac events were concerned, whether it's atrial fibrillation, ventricular tachycardia, or hypertension, there was a distinct advantage of acalabrutinib alone. When acalabrutinib was used alone, the number of patients who had grade 3 or more reactions was much lesser. And unlike ibrutinib, where discontinuations, dose reductions were very common, in the long-term CL001 study of acalabrutinib, what was noticed was that patients remained on therapy for a long period of time, suggesting that it's a very well-tolerated therapy. The second trial which helped acalabrutinib get its place in the history of CLL was the Ascend study. Here, we had again 3 arms, acalabrutinib given as 100 milligram twice a day, and the other 2 arms were idelalisib with rituximab and bendamustine rituximab, BR. Again, the primary endpoint was PFS, because crossover from these 2 arms was allowed to go into acalabrutinib if there was progression of disease. And what did we see again? A similar 73% risk benefit against the other 2 arms, where acalabrutinib was found to be beneficial. But what if we were able to split it up? Then it was a similar advantage of acalabrutinib over each of the protocol, that is idelalisib, rituximab, or BR. We know that BR is commonly used in our country, but if you were to use acalabrutinib alone, it's oral, it's twice a day, you sit at home, side effects are lesser, there's no hospitalization as opposed to BR, and the ancillary expenditures are lesser. Yes, acalabrutinib as of now, including with the patient-assisted program, is expensive, but it's an oral drug which can be taken from home. And you see across the different patient subtypes or subgroups, whether it is about biology or patient characteristics, there was a definite favor towards acalabrutinib in this trial. So acalabrutinib is used as 100 milligram twice a day. Tell your patients that both with ibrutinib and acalabrutinib, you will see an early lymphocytosis. It will settle over a period of 3 to 5 months, depending upon whether you're using it in early untreated phase or treated phase. There is a certain amount of risk of hemorrhage in patients receiving antiplatelets. So like ibrutinib, DOACs would be preferred. Grade 3 hypertension and atrial fibrillation were very less in patients with acalabrutinib. So cardiac patients might benefit if you want to use a BTK inhibitor with acalabrutinib. 2 things I have found common in them. One is headache and the other is giddiness and arthralgia. I've not seen so much of neutropenia as of now. Co-administration of proton inhibitors should be avoided. And if you want to give it, there should be good spacing between the two. And if you got any drug which has a CYP3A inhibitor or inducer, then please be careful and adjust the dose of acalabrutinib accordingly. So as of now, if you look at the NCCN guidelines for CLL, SLL without deletion 17p, the preferred regimen, irrespective whether the patient is frail or whatever be his age, is the BTKI inhibitor, either alone or with combination with a monoclonal antibody. And the same is the thought when there's deletion 17p. That means these agents are able to overcome the high-risk features of CLL. And in the relapse category also, if you see, it is the same story. It is again the BTKI inhibitors alone or in combination that will make a difference, irrespective of frailty or the age of the patient. And likewise, in those with deletion 17p, the same drug. So it now appears that irrespective of the age, frailty, or the risk status of the patient, BTKI inhibitors can make a huge impact on the management of CLL. What about acalabrutinib versus ibrutinib? This is a relapsed refractory treated CLL. It was the first randomized phase 3 study which was done. If you look at all the characteristics which I mentioned here, there is no difference between acalabrutinib and ibrutinib. And they came up with the conclusion that both are similar in terms of various aspects. But the most important is acalabrutinib has less cardiovascular adverse events. Now, this is more important for patients who have a pre-existing cardiovascular event. They might benefit out of acalabrutinib. But in all honesty, if you look at the graphs of PFS, OS, or event-free survival, really, there's not much to choose between the two. Therefore, for patients who've got the ability to take acalabrutinib and buy it, it's fine. It's a twice a day as opposed to ibrutinib. But really, ibrutinib can also do the job very well, unless the patient has got side effects or the patient has developed some cardiac events, making him unable or unfit for taking ibrutinib. And when we looked at the specific cardiac events, hypertension, arrhythmias, cardiorespiratory arrest, any types of arrhythmia for that matter, interventional procedures, cardioversion, atrial fibrillation in older patients, either not having it and getting it de novo, or though already had atrial fibrillation and wanted treatment. In all these cardiac conditions, there's no doubt acalabrutinib was superior to ibrutinib in terms of side effects. My last point is, what if I use acalabrutinib in combination with other inhibitors? Let's go complete chemo-free and give acala, venetoclax, and obinutuzumab. This is a single-arm, open-label phase 2 study where we try to look at new agents and frontline treatment, and they matter. They make a difference. So we could get unmeasurable, undetectable, measurable residual disease in the bone marrow in a large number of patients by cycle 16 with, yes, neutropenia, but never grade 3 and other things which were significantly, which are not significant enough to affect the quality of life of the patient. And there were no deaths on this study. The primary endpoint was to achieve CR with an UMRD in the bone marrow. We know that in peripheral blood, you might have UMRD, but the truth will be in the bone marrow. Even the bone marrow has to be having a UMRD. So people will do bone marrow UMRD only if the peripheral blood shows a UMRD. And what is interesting to note over here is that whether it's peripheral blood, whether it's bone marrow, whether it's mutated or unmutated state of IGHV, or whether it's TP53, in all of them, this combination worked very similarly, such that by cycle 16, there was a significant amount of control of the disease process that you will see, irrespective of what was the biological status of the patient. And this persisted up to the cycle 25, which means it gives us an opportunity to be able to either taper or reduce or stop one of these agents and only continue acalabrutinib on long-term basis, giving us a functional cure like we saw with FCR and mutated IGHV. And if you look at the swimmers plot, the one in the blue are the ones who are off treatment. Many patients have been off treatment and continue to remain disease-free, which is a very important milestone in the treatment of CLL. Imagine a young patient who's say 55, 60, 65 and has another 10, 15 years of life to go through. Will he just keep taking medicines all through his life, or will he be able to be off therapy with a finite line of treatment? I think it's extremely exciting. So I'm going to thank you very much for the opportunity. I'm going to leave you with a few words that, yes, I understand what Joseph John said was very important. 8 years of ibrutinib. We have lesser years of acalabrutinib. But, you know, everyone has started somewhere. I remember when ibrutinib came in first also, there were a lot of questions being asked and there was worry. And it was a long time, a long hiatus before it was used. And now it's used like water, possibly because it became generic hence. But acalabrutinib also will turn out to be a good drug. Over a period of time, it will also show its true colors and give us the benefits. It would be safer in cardiac patients. It's been shown to be effective even in long-term patients. Their ability to continue for a long period of time is good. And I'm sure as time goes along, there'll be more trials of combination with acalabrutinib, giving us finite duration, deep responses, UMRD, and possibly the treatment-free remission. And I love the way Joseph John gave the analogy between CML, CLL. We might have a TFR tomorrow also with this agent. Thank you very much for your patient listening.
Thank you, Dr. Abhay, for complimentary talk to Joseph's talk. And continuing the trend in CLL, I think we can have Dr. Rahul Nathani, who would be speaking on the other agent which is used both with ibrutinib as well as with the acalabrutinib, Gazyva or obinutuzumab. So Dr. Rahul Nathani, please.
Good evening, everyone. Thank you very much, organizers, for giving me this opportunity. And much has been talked about the management of CLL by BTK inhibitors. The topic assigned to me is the role of obinutuzumab in management of chronic lymphocytic leukemia. Now, we all understand that CD20 is an important target for B-cell malignancies. For one simple reason, it is expressed in approximately 95% of B-cell malignancies. And its extracellular epitopes are easily recognized by the monoclonal antibodies. Now, obinutuzumab or Gazyva was a smart molecule. It was actually engineered to overcome the rituximab resistance. And so it's a first glycoengineered type 2 anti-CD20 monoclonal antibodies. And what it basically does is basically removes the sugar residue from the FC region and thereby enhancing its antibody-dependent cellular cytotoxicity. And the type 2 nature of the antibody causes increased direct cell death and also antibody-dependent phagocytosis. So obinutuzumab has shown superior activity against rituximab and improved efficacy, and it's important to note in preclinical non-Hodgkin's lymphoma models and in some of the clinical studies. Now, why CLL11 study was designed? So we all understand that patients of CLL are elderly, and by that time many of them will have comorbidities. And in that population at that point of time, there were no conclusive evidence that any other treatment was superior to the poor man's medicine, the chlorambucil. And they were encouraging phase 1, phase 2 data regarding the combination of anti-CD20 antibodies. So the aim of this study was to show that patients who have CLL and comorbidities, the chlorambucil plus anti-CD20 monoclonal antibody was superior to chlorambucil alone. And the stage 2 of this study was the comparison of Gazyva and rituximab along with chlorambucil. So this was the study design of CLL11, where the chlorambucil, obinutuzumab, and rituximab were in 1:2:2 arms. I will talk more about the stage 2 of the disease, which directly compares Gazyva chlorambucil versus rituximab chlorambucil. The primary endpoint was progression-free survival. So if you look at the baseline demographic parameters, they were similar in both the arms, including the median age, SIRS score, ECOG scores, the unmutated IGVH, and deletion of 17p. The key results of the primary analysis in 2013 were that the median progression-free survival was 26.7 months versus 15.2 months in the rituximab arm. This is one of those very few studies which is directly comparing these two monoclonal antibodies. The median overall survival was not reached in both the arms, and the MRD negativity was higher in Gazyva arm. In terms of the safety, infusion-related side effects were more in the Gazyva arm, and the serious side effects were borderline higher in Gazyva arm. This analysis was updated in 2015, and here we will see that the median progression-free survival has moved to 28 months. The time to next treatment was 51 months in the Gazyva arm versus 38 months in the rituximab arm. The median overall survival was still similar. Now, the final analysis, the data cutoff, data was censored on 10th of October in 2017. And by this time, the median follow-up time in the Gazyva arm was 62 months, which is a good 5 years for both the arms, Gazyva and rituximab. If you look at the adverse effect, the more than grade 1 adverse effects of any grade were seen in similar number, more than 90% of the patient. Grade 3 to 5 adverse effects were seen more in Gazyva arm. Serious adverse effects were again slightly more in the Gazyva arm. If you look at the second malignancies or infections, they were similar in both arms. If you look at the late onset adverse effects, the prolonged neutropenia was more in rituximab, and late onset neutropenia was more or less similar in both the arms. The second malignancies or the squamous cell carcinomas and the basal cell carcinomas were okay. No new late onset toxicity was detected at this point of time. Now, in the final analysis, if we look at the Gazyva versus rituximab chlorambucil, there was a clear-cut advantage in progression-free survival in Gazyva compared to rituximab, with a hazard ratio of 0.49. The 5-year progression-free survival was 23%, and it was 9% in rituximab. The time to next treatment was significantly more in the Gazyva arm compared to rituximab arm, with a hazard ratio of 0.58. So one of the few studies which show overall survival advantages in CLL, and here the overall survival was significantly more. It was 66% 5-year survival versus 57% in the rituximab containing arm. Again, the forest plot says that actually the parameters are across unity, but if you look at the age less than 70, age more than 75 and beta-2 microglobulin high, this arm was favoring more on the Gazyva side. Even though the study investigators have bet not the unity but at a 0.8 mark. The number of deaths were similar, and the follow-up duration, the main causes of death were either adverse events, disease progression. The survival follow-up period was for surviving patients were 80 months versus 99 months. The main cause of death in both the arms were disease progression and largely similar. So after a median observation time of approximately 5 years, the Gazyva chlorambucil arm maintained an acceptable and manageable safety profile. It provided a clinically meaningful improvement in progression-free survival and overall survival. Versus rituximab arm, it provided 51% reduction in risk of progressive disease or death and 24% reduction in risk of death. And accordingly, it prolonged the time to next treatment related to rituximab by 1.5 years. The final analysis of the CLL-11 study supported the use of Gazyva chlorambucil as first-line treatment for CLL patients with comorbidities, and it also suggested that Gazyva is the preferred anti-CD20 antibody if pocket allowed over rituximab. Now, there was an interesting network meta-analysis on the first-line treatment strategies for previously untreated patients with CLL. The study aim was to assess the efficacy of different first-line therapies regimes using chlorambucil monotherapy as a reference, and to provide a hierarchy of the best treatment options for previously untreated patients. And the RCTs that compared at least one treatment regime to another or to observation only in previously untreated patients were included. So data from 33 RCTs were included in this, and the final network was constructed from 21 first-line treatment regimes with the data of 11,600 patients. The primary endpoints were overall survival and PFS. So this is the forest plot, and again, these were the studies where chlorambucil was one of the main control arm. Now, surprisingly, if you look at this forest plot, the CHOP, fludarabine, even FC, alemtuzumab, fludarabine was not doing well. FCR was doing better compared to chlorambucil. And in this study, in this forest plot, based on the hazard risk of the, the studies are not directly comparable. So hazard ratio was taken. The Gazyva chlorambucil was providing the best reduction in hazard ratio. So the authors concluded that Gazyva chlorambucil combination provided superior 99% superiority over chlorambucil, while FCR provided 96%. The statistical number gave, but the hazard ratio was lesser with Gazyva. Now, there are novel approaches where Gazyva combinations have been tried in different clinical trials. So the Elevate-TN trial was discussed by Dr. Bhave just now. It was basically a 4-year follow-up of the study was published. The study largely composed of 3 arms. One arm contained obinutuzumab and acalabrutinib. One arm was acalabrutinib monotherapy, and the third arm was obinutuzumab along with chlorambucil. If you look at these arms, the response rates were significantly high when acalabrutinib was combined with Gazyva. Even the acalabrutinib alone was also giving very good results, but combination with Gazyva improved the response rates significantly, with high number of CRs, high number of undetectable MRDs in these patients. In fact, this if one was to use till that time, the best combination, the best results would be with obinutuzumab plus acalabrutinib. So it maintained its efficacy and safety versus chlorambucil Gazyva combination in treatment naive CLL patient. Significantly longer median PFS for Gazyva plus acalabrutinib. Then there's an Eliminate study where ibrutinib was combined with Gazyva. The Gazyva was given for 6 cycles. Again, the schedule of Gazyva, all of us understand that the schedule is day 1, 850, and then day 1 of cycle 2 to 6. And the day 1 dose was split into 100 milligram on day 1 and rest 900 milligram on day 2. CLL14 study has allowed the full 1000 milligram to be given on the day 1 itself. But so far, majority of protocols have used 100 milligram on day 1 and 900 milligram on day 2 of cycle 1 day 1. So the study, Eliminate study, had ibrutinib along with obinutuzumab for 6 cycles and compared with chlorambucil and obinutuzumab. And the data was as expected. The progression-free survival was significantly superior for ibrutinib plus obinutuzumab combination. This superiority of results were maintained whether the progression-free survival was assessed by the cytogenetic risk status or by the bulky disease status. So the forest plot says that this group, the obinutuzumab and ibrutinib combination fared better in literally all the parameters that were studied. The secondary efficacy endpoints, so the overall response rates in ibrutinib obinutuzumab were 88% versus 73%. The CR rates were 19% versus 8%. And these numbers were correspondingly higher in the higher risk patients. So in high risk group, 90% of the patients in ibrutinib and obinutuzumab arm responded, and 14 of them attained CR or CRI. The MRD undetectable again was there in 27% of the patients in high risk group and 35% in the all-inclusive patients group in ibrutinib plus obinutuzumab arm. So at median follow-up of 31 months, the median overall survival was not reached in the either arm. So this study concluded that in previously untreated CLL SLL patients, ibrutinib plus obinutuzumab significantly improves progression-free survival versus obinutuzumab plus chlorambucil, independent of the high-risk features. The higher rate and depth of response in the ibrutinib and obinutuzumab arm. Toxicity was consistent with established safety profiles with no new safety signal coming out of this. So authors concluded or suggested that ibrutinib plus obinutuzumab should be considered as an effective chemotherapy-free first-line option for these patients with high-risk group. And then we'll discuss the CLL14 study trial because earlier we were talking about the chemotherapy, the FCR versus BR, then we were talking about the chemotherapy-free regimes, and now we are also looking at a fixed duration or the finite therapy treatment for CLL. So this was a phase 3 trial with venetoclax and obinutuzumab versus chlorambucil and obinutuzumab. The schedule of obinutuzumab was similar in both the arms, but venetoclax was slowly or gradually increased from 20 milligram to 400 milligram over a 5 weeks period because of high risk of tumor lysis syndrome with venetoclax. So the results were significantly superior in venetoclax containing arm with 88% of the patients having a 2-year progression-free survival versus 64%. The median progression-free survival was 36 months. However, in venetoclax obinutuzumab, it was not reached with a hazard ratio of 0.31. 36 months estimated PFS was 50% in chlorambucil arm, while it was 82% in venetoclax and obinutuzumab arm. If we go by the IGHV mutation or TP53 mutation, again, the venetoclax containing arm was doing a significantly superior. So if you had venetoclax, actually, whether IGHV mutation did not make any difference, and similarly for TP53. Now, tumor lysis syndrome is a known side effect of venetoclax and lymphoid malignancies. So the authors suggested that how we could reduce this risk was, in the first week, we give only 20 milligram, then increase the dose to 50 milligram in the second week, increase the dose to 100 milligram in the third week, then 200 milligram on week 4, and then come to the full dose, which is 400 milligram week 5 onwards. Now the tumor lysis prevention has been advised by authors, and they divide TLS into low risk, medium risk, and high risk. And they define low risk as CLL, SL who have nodal mass less than 5 centimeter and absolute lymphocyte count of less than 25,000. While high risk was a nodal mass more than 10 centimeter or more than 5 centimeter, but lymphocyte count of more than 25,000. And they suggested that low risk could be an oral hydration at home, while high risk patients could be admitted for first 2 weeks till the dose of 50 milligram venetoclax is ongoing, along with hydration and serial monitoring of tumor lysis profile at after the administration of medicine at 4 hours, 8 hours, 12 hours, and 24 hours, the first dose. If you look at the adverse effect in the both the arms, so grade 3-4 adverse effects were similar. Neutropenia was slightly more common in venetoclax arm. The febrile, and accordingly febrile neutropenia were more common in this thing, and infections were more common. All grade TLS were similar in both the arms. The infusion related reactions were similar, and the deaths during the treatment were slightly higher, a shade higher in the during and after treatment in venetoclax obinutuzumab arm. There was a good impact on MRD status, and venetoclax plus obinutuzumab arm led to higher rates of undetectable MRD levels in blood and bone marrow. It was more effective in MRD eradication and clonal growth modulation with venetoclax plus obinutuzumab arm. And MRD kinetics analysis does suggest that there is a possibility of MRD guided limited duration therapy in future in these patients. Now, all of us have been using rituximab, has done a great, good for lymphoid malignancies in India and any other cost sensitive center. So we have a lot of data and studies available now which talk about obinutuzumab combination, for that matter, ibrutinib, acalabrutinib, and other. We are kind of spoiled for choices in CLL management these days. But when we talk about the obinutuzumab, most of us would be convinced about the response rates now. But when it comes to choosing these two agents, how do we actually decide? So many of you may have read this novel by Charles Dickens, A Tale of Two Cities, which was actually the story of a French Revolution. Now, with the advent of obinutuzumab, there's also a tale of two antibodies, the obinutuzumab versus rituximab. As I discussed earlier, that obinutuzumab was, a glycoengineer. It was designed to overcome rituximab resistance. So theoretically, what's the difference between these two? So rituximab is a type 1 monoclonal antibody and obinutuzumab is type 2. And how we differentiate is in rituximab, there's a localization of CD20 into the lipid wraps. There is no homotypic adhesion. There's a minimal direct cell death, which is the main difference between these two. The full CD20 binding capacity at saturating conditions, which is the pitfall here. Prominent complement dependent cytotoxicity, prominent antibody dependent cellular cytotoxicity, and antibody dependent phagocytosis. Obinutuzumab, on the other hand, does not have any localization of CD20 into the wrap. It causes homotypic adhesion. It's a more potent direct cell death. It is a half maximum CD20 binding at saturating conditions. It has minimal CDC. It has more potent antibody dependent cellular cytotoxicity and more potent antibody dependent phagocytosis. So on lab model and the preclinical studies, obinutuzumab is a very smart molecule and is significantly superior to rituximab. If you look at the side effects of these two molecules in terms of what data is available with several trials. So in Gauss trials, if you look at the infusion related side effects were significantly more in all the trials in Gazyva containing arm. So 74% versus 51%, 69 versus 39, 59 versus 48, 45 versus 31. With our own experience of Gazyva uses in quite a few patients now, we have not seen these infusion related adverse effects to be, clinically significant or relevant. So they do come, but they are not clinical, they're easily manageable. The grade 3 IRRs are again more with Gazyva arm compared to the rituximab arm. The neutropenia was slightly more in the Gazyva arm in some studies. The grade 3 infections were more or less similar in both the arms. Grade 3 thrombocytopenia was more or less similar in rituximab or Gazyva arm. These are the references for these 4 studies where this data is robustly available. Now, when originally Gazyva and rituximab were tried in, the treatment naive low-grade non-Hodgkin's lymphoma, the indolent NHL, where rituximab monotherapy or Gazyva monotherapy as weekly into 4 doses were used, there was no difference between these two molecules. A very smart molecule in lab, but clinically was not doing well for this. Similarly, when such a thing was tried for diffuse large B-cell lymphoma, the previously untreated DLBCL, and again, large 700 patients both arms, there was no difference whether it was Gazyva CHOP versus rituximab CHOP. So that was a setback for Gazyva, that rituximab and these were doing fairly, even though theoretically it was superior. But slowly the data evolved. And yeah, in the first graph, we had seen that monotherapy, there was no difference. But when Gazyva was combined with chemo versus rituximab and chemo in untreated follicular lymphoma, there was a significantly superior progression-free survival in this graph. So Gazyva proved its superiority in low-grade lymphomas here. And this is the CLL-11 study, which we had discussed, the Gazyva chlorampicil versus rituximab chlorampicil. So in CLL population, if we have to see which monoclonal antibody to use, at least theoretically, and now we have clinical data available, that Gazyva is significantly superior to rituximab as an anti-CD20 partner in treatment of this disorder.
Yeah, Dr. Rahul's a great presentation, but need to conclude, sir,
Yes,
please.
I'll just complete. So these are the cumulative doses, and this is the pitfall that obinutuzumab dose exposure was higher, and probably that we are aware of these guidelines that acalabrutinib, obinutuzumab, venetoclax, obinutuzumab can be used. I think my presentation is hung, but this is the last slide. Yeah, so to conclude, we know Gazyva is a novel glycoengineered type 2 monoclonal antibody. CLL-11 trial had enrolled older, frail patients with significant coexisting conditions. And this is the trial which has proved superiority of Gazyva over rituximab. And recent clinical trials have shown that obinutuzumab combination are associated with longer progression-free survival, benefits seen also in TP53 mutated patients and patients with unmutated IGH heavy chain. Thank you.
Yeah, thanks, Rahul, for this excellent presentation. I think these sessions don't have a space for discussion, but I think all of you, yourself, Abhay and Joseph, you have covered the topic beautifully. And I have only to say that, all the big pharmaceuticals should thank that there was a chlorambucil there as a comparator arm. But yeah, I mean, these are very, very interesting drugs, and these are very interesting times for B-cell malignancies in the days to come. So I hand it over to the organizers. Ankur, if you can take it over from here.
Sir, before the end, I have a question to all the CLL strategic team. Going through all these discussions, it seems that soon the time will come that rituximab and bendamustine will not be there, and the treatment will be shifted to Gazyva and this acalabrutinib and ibrutinib. So, is this the right time to offer these molecules at first hand to Indian population? Is it really worth to have such a costly medications to be offered to the patients who are visiting us in the OPDs and telling them? Anyone, means all are seniors to me, so I would love to hear anybody.
So I mean, Ankur, as far as patients are concerned, using one drug to another, you will have to look at certain characteristics of the patient, characteristics of the disease. I mean, if you're going to use BR for a high-risk patient, then you're wasting time. So your choice of the patient, your choice of the patient's comorbidity, and your counseling of the patient. So you may want to give the best drug, but they may not be able to afford it.
Yes, sir.
So I don't think we can write off BR because it's available at a rate which is good. But in the COVID era, people don't want to come to hospital. Ibrutinib available as a generic. And I think Joseph John had mentioned that lesser doses also working. And remember, you're not curing the disease with BTK inhibitor. You're controlling it.
Yes, sir.
Therefore, you're not looking at deep responses as you see in CML. But you want to have a number of white cell count which has come down. a patient who gets back to normal life, a patient who says, I'm being treated and I'm feeling well, lymph nodes are coming down. The lymph nodes disappear with BTK inhibitor. It's beautiful. They just melt, which is why the lymphocytosis increases initially. So, there is a lot of feel-good factor. It's an oral medicine. Ibrutinib has the advantage of being just once a day. Acalabrutinib, my patients have a problem because it's twice a day. Sometimes they remember, sometimes they don't remember. So you have to see all these things before you decide. I don't think it's so much about cost as it is about the need. The scientific need should precede. And if they can't match the scientific need because of finances, so be it.
Right, sir.
So I think it will be genetics of the disease, fitness of the patient or comorbidities, whichever way we want to. And third is the economics. These three basically make an algorithm and patient go into that path.
Right, sir.
I'd love to know what Shuparno thinks. Shuparno, Vamoshay.
Hi. No, I mean, you are absolutely right. I mean, on this front, the major reason why we could not use ibrutinib earlier was the cost, the affordability. Now that it's affordable, I think every patient should get the opportunity to be exposed to ibrutinib. If it's going to be a long-term treatment. See, the standard regime that we follow right now is BR followed by maintenance rituximab. Okay, that's still the data. Now, if we are going for ibrutinib, it has to be continued indefinitely as of now. So that's one downside. I don't know whether you have tried stopping it after it's MRD negative for a certain duration. Whether you have tried that, but again, that's something to consider. But majority of our patients use it at a slightly lower dose than usual when we are using it for a prolonged duration. Older patients, we don't give it at 3 tabs beyond a certain time. They come down to 2, and if they can be fine with 2 for several years, I see nothing wrong in it. I mean, we have achieved our goal.
I wonder if Pankaj is there in that paper which is written, whether the incidence of resistance goes up if you use a lesser dose of ibrutinib, because you're not really suppressing the entire BTK or inhibiting it or the clone. So is Pankaj around or he is left?
No, I'm there. So,
Pankaj.
So it was a short follow-up, so we cannot make out.
Okay.
My only difficulty with using upfront these therapies are that at 5 years only 40 to 50% of patients actually are on these therapies. Rest of the 50% of patients actually will either develop side effects or will develop complications or will develop resistance. So even though you start on ibrutinib, but you should be sure in a young patient what will happen after 5 years, because there is a very high chance that he would develop either side effects or complications, or he would not be on ibrutinib.
So one of my worries, Pankaj, is that if we use a lesser dose and we are happy with that, over a period of time, if we develop resistance, then we cannot use acalabrutinib. You can use acalabrutinib if it's intolerant to ibrutinib, but not if it's resistant, because they use the same mechanism. So resistance to ibrutinib is equal to resistance of acalabrutinib, which means you're one drug short. So that's where my worry is about this lesser use of ibrutinib.
No. So the lower dose of ibrutinib initially came into use in US only. The problem is Johnson there, stopped manufacturing 140 milligram now. It is available only in 420 milligram. Whereas in India, it is available in 140 milligram. And I'm not sure whether there would be any resistance or not, but I have full faith in Indian pharma, and hopefully generic venetoclax will come by that time.
Yeah, I agree with you, Dr. Pankaj, because look, we cannot afford to give 30,000 lifelong per month. So we need to be very practical. Patient preference and cost. Cost is the limiting factor. So if we were to extend somebody's life for 10 years, which is 3.6 lakhs per year, and say it is 36 lakhs. And if you add the inflation and the other things, it is much more than that. So we cannot do that. So our routine strategy is basically to give all the 3 drugs, all the 140 into 3, 5 or 20, And as soon as they reach the normal counts, start tapering to 2 and 1. Now, we are anticipating the possibility of a resistance because of a lower dose. Reasonable. We are actually borrowing the idea from antimicrobials. I am not too sure about imatinib lower dose actually causes resistance. We were to reduce the doses because of side effects in most of the situations. So I really don't know whether we can extrapolate the antimicrobial philosophy to cancer. If some thoughts, I'll be very happy to hear that.
Less than 300 of imatinib also did not work well. Up to 300 was published.
Correct.
Less than 300 was not supposed to be good.
I agree. So here we are not worried about anything else. I mean, anyway, we are bringing a stage 3 to stage 1 or 2 and then leaving him there. No?
So, Dr. Abhay, there is data from the US where the lower dose is able to saturate, is able to inhibit the BTK. So,
how long is the follow-up?
Yeah. So many times, actually we have seen that in the West, they use a higher dose. I mean, I use a lower dose of ATG in aplastic anemia, and that works very well. We use many times, we use a lower dose of IVIG also in ITP or in many other situations, and they work. So
next thing,
can I say something over here, Pankaj?
Sure.
Yes, sir.
See, we have talked about it between ourselves a lot of times, and I very firmly believe, and I keep on saying this, that we cannot replicate, the Western pharmacogenomics on our population. I mean, no other, civilized country does it. I mean, Japan would not accept any licensing based on what FDA or EMA has done. We need to do studies on our population before we accept a dosage or a regimen as suitable for our population. As you all well know that, for example, L-Thrombopag is used as a starting dose of 25 milligram in Japan after studies were conducted over there. They don't use 50 milligrams.
Yeah.
And we know there are a lot of pharmacogenomic variations, and within the country there would be a lot because we are not a homogeneous genetic population. So I think there is a lot to learn about dosing of all these drugs in the population that we deal with. As regards, when we are talking of younger patients versus older patients, if I'm talking about a 75-year-old, maybe ibrutinib oral therapy might be suitable. But as Pankaj also said, that for a 55-year-old or 60-year-old, I mean, maybe BR followed by maintenance rituximab and wait for relapse before introducing ibrutinib to that patient. It's just like we are treating myeloma right now, right? That we are just keeping our options up the sleeve.
Yeah. I mean, I'm also interested in the fact, I'm sorry, Ankur, I know we are overshooting time.
No, sir, it's okay, sir.
There was a Clarity trial where ibrutinib and venetoclax were combined together for a finite period of time. And it showed quite a good result. So I'm sure if we were to use something which is finite, like Rahul mentioned, and then keep them off therapy and just observe them and reintroduce the drug if there was to be a relapse, might also be a very good idea. It gives a treatment-free remission to the patient, gives some time off from spending money on drugs, makes them feel less like patients. It might be a good idea to try some finite therapy, but it's try because we don't know. And you should try it only if, and stop only if you achieve a significant UMRD. Those patients will probably do well. And I think that's something that I would look forward to in CLL. I would not want to have a patient age 50, 60 taking this BTK inhibitors on long-term basis, because over a period of time, they're going to stop taking it. They're not going to follow up and they're going to have side effects and it'll be a mess. So if you can hit them hard, hit them deep for a finite time, they're going to be more compliant.
I think, Abhay, the combination of venetoclax, obinutuzumab, and either of the BTK inhibitors has been used for finite time, although it's a very small trial on a small number of patients, but it has shown that you can stop the treatment on achieving MRD negativity and they remain in remission for a duration. which is not reached. I mean, the PFS, median PFS is not reached. So it's possible. I think it's quite possible. With the combination therapy, it's quite possible.
Great. Thank you very much. Thanks, Ankur. Thanks for getting us all together. It was a nice discussion.
Yeah,
Thanks so
absolutely.
much. Thank you so much, Ankur.
Thank you, everyone.
Thank you.
Thank you.
Bye.
At the end, I just want to say thanks to everybody, and I would like to extend my sincere gratitude to all the faculty, delegates who have logged in for the great discussion and learning. And I would like to acknowledge all my academic partners for the generous support. But at the end, either it is an advantage or disadvantage of these virtual sessions that it is followed by a refreshment which I taken at home. Not we can meet physically and we can have a good time. So at the end, I would like to say that don't forget to log in tomorrow for another session, that is the lung cancer updates tomorrow at 6:55 p.m. Thank you, everyone, and thank you, sir, and thank you all speakers and all chairpersons for sparing the time and joining for this session.
Bye, Ankur. Well done. Bye.
So
Bye,
thank
sir.
you. Thank you, everyone from the organizing team. Stay safe. Good night. And let's log in tomorrow. Have a great evening to everyone.
Thanks. Bye-bye.
Guys, thank you, sir.